changing again the subject, and here we are going to work on extra-axial intracranial lesions and how actually are going to deal with the differential diagnosis. So this is the layout of the lecture, and as you see, it's divided into two components. One, we are going to speak about the non-neoplastic cysts, which are common extra-axial lesions, and then the two more common extra-axial tumors that you may have, meningiomas and schwannomas, primary. Then we have differential diagnosis regarding the areas, the cellar and supercellar region, the external lesions, the skull and the meninges, and the interventricular compartment. We are not going to be able to view all of them and all of the possibilities, but just ones that are actually more frequent. So to understand which type of lesions we can find in the extra-axial space, we need to understand what is there. So intra-axial, by definition, is everything that affects the brain. Outside the brain, we will have the extra-axial component. So it may be extradural, so it may be at the epidural space at the bone and outside the bone. Intradural, so between the dura mater and the arachnoid, so it will be the subdural space. And we have also intraventricular possibility of location. So extradural, we are going to skip this because it's going to affect mainly the bone and the vessels, and the bone will be affected by tumor, most commonly secondary tumor. And there are some specific primary tumors, especially at the skull base. This is a case of a plasmacytoma. Then the intradural space, we have seen already the subdural space with the subdural hematomas. And we have also the subarachnoid space, and we have also the possibility to have lesions like this one, which is a dural-based metastasis. And then intraventricular, what we have the ependymom, we have the choroidal plexus, and we have CSF, and again here the same patient with the intraventricular metastasis and an infiltration, as you see here, of the ependymom of the lateral ventricle. So first thing, the classical signs regarding an extra-axial lesion, what are we going to find? So we are going to have the blood vessels that are going to be displaced, and they will be in between the lesion and the cortex. We will have a widening of the subarachnoid space, especially at the base of the implantation of the lesion, with a CSF cleft surrounding the brain, the extra-axial lesion from the brain. And we may also have adjacent changes in the bone, typically for meningiomas, the hyperostosis, and for other lesions we may have some scalloping, meaning remodulation of the bone. The gray and white matter junction will be preserved, and there will be obviously a compression and a deviation, but of both cortex and subcortical white matter. And this is what we see here. So it's completely surrounded by brain, but we understand that is an extra-axial lesion. You see the blood vessels are at the periphery of the lesion. There is a CSF cleft all around this meningioma that is here. So it's clearly easier to look. You see there is the cortex there, and the cortical white matter junction is preserved. Well, we will have some cysts. We have already spoken about cystic lesions that are associated with infection, so we are going to skip that, and we are going to see some of the cysts that are more common, especially the arachnoid cyst, the epidermoid cyst that we have here demonstrated, the neuroenteric cysts, which are more rare, and the pineal cysts, which are very, very common. Intraventricular, we also can have the colloid cyst with a typical location at the third ventricle, and then the choroidal plexus and ependymal cysts that are located inside the ventricles, and they are called like that if they are inside the choroidal plexus or at the ependymom. So the arachnoid cyst is very, very easy. All the signal intensity on MR and on CT, the density on CT will be equal to the CSF. Well, there are a couple of exceptions. If we have a loculated arachnoid cyst, the signal intensity on T2 flare may be a little bit higher than the CSF. It's important to look at the diffusion. There is no restriction, and then there is always the reduction in the signal intensity from T2 to flare or dark fluid. On the other hand, epidermoid cyst, you cannot make the differentiation from epidermoid cyst to arachnoid cyst only on CT. You are going to need to look at MR. And what is going to be the major positive findings? On dark fluid or flare imaging, it does not follow the signal intensity that it has the arachnoid cyst. It has the signal intensity different from CSF and has restricted diffusion on the diffusion images. And these are the two features that allows you to make the differential diagnosis between an arachnoid cyst and an epidermoid cyst. And you see here, because on T1 and on T2 would be very difficult, and on CT you also not going to be able to make the differential diagnosis. Well, what about dermoid? Dermoid is whenever there is fat in that cyst. And you are going to confirm that doing a fat sets sequence that will actually reduce the signal intensity on the T1 images. These have some possibility to rupture and have a chemical meningitis, as you see here, with all the components of the cyst in the subarachnoid space. So the key point here is to look at the presence of fat, and you do that confirming with the fat sat or looking in the CT to the fat density. Well, neuroenteric cysts are rare. They are endodermal cysts, and they can be present all the way from the spinal cord to intracranial. They are generally at the midline or just slightly off the midline. And the signal intensity is very variable on CT and on MR because it will depend on the content of the cyst, if it's more fluid or if it has more proteins or mucin. So there is no clear signal intensity specific to define it. How we define it? We define it by the location, generally at the midline and on the ventral portion on the brain, all along the skull base, and it can also happen in the spine. Then we come to the two most common tumors and primary tumors, and the first one will be meningioma. So how actually are we going to suspect that there is a meningioma? So it's an extra-axial lesion, mostly located at the dura of the skull base or the cranial vault, but you may also have meningiomas inside the ventricles. So they will exhibit calcifications frequently, as you see, some low signal intensities inside the lesion, and you see it better if you do your T2 star or if you use the CT. They have a strong contrast enhancement, and it's a solid one. Generally, it's a solid lesion. Then it will have associated bone hyperostosis, so increase of the thickening of the bone where it actually is implanted. And you may have a dural sign that we don't see here, but it will be an enhancement of the dura, linear enhancement of the dura nearby the area where it is implanted. It's a high vascular lesion, so as the other ones that we have seen, if you do an angiogram, you are going to see a capillary blush and meningeal vein arteries dilated. So sometimes, and especially the ones that are have even higher vascularization, you may see flow voids inside or at the periphery of the meningioma. Another case of a meningioma of the craniovertebral junction, you see typical morphology of an extra-axial lesion. You see it's isointense on T1. slightly hypointense on T2, and you see the thickening of the bone where it's inserted, and you see this radiary shape, linear shape, and with a radial fashion. It may be the vessels there. It's slightly hyperintense on flare and dark fluid, and you have strong contrast enhancement, and in this case you don't see intra lesion calcifications. The other important tumor, extraaxial tumor, will be schwannoma. And for your differential diagnosis, when you are looking at the skull base, if you put schwannoma, you should also put meningioma in differential diagnosis. They are slightly different. And the difference is schwannomas tend to be more hyperintense on T2. This is a T2 cyst, high-resolution T2, and you see the lesion inside the internal auditory canal in relation to the cranial nerves. So this is a vestibulocochlear schwannoma. Another thing is that meningiomas tend to induce a hyperostosis, and on the opposition, the cranial nerves tumors will actually enlarge the foramen where they pass. And this is the typical example. So you see a very enlarged internal auditory canal, and you see a lesion inside that is slightly enhancing, and this is a vestibulocochlear schwannoma. You see the signal intensities on T2, flare imaging, T1, and T1 post-GAD with contrast enhancement, and in this case, a complete solid lesion. You may have some cystic components associated with schwannomas. So regarding skull and meninges, you have seen some inflammatory lesions, infections and non-infections. You have tumors. Obviously, secondary bone tumors are very common. They affect the bone of the skull base and cranial vault, but also you can have dural metastasis and even dural carcinomatosis. The primary, most common from the meninges is the meningioma. Then there are many other tumors that we are not going to have time to speak about that can actually affect the bone and the meninges. Just giving you two examples that are typically for the differential diagnosis. At the skull base, you need to think about the chordoma. So it's a lytic lesion of the clivus, and this is resulting from the remnants of the notochord. It's benign, but it's locally invasive. So if it's continuing to grow and destroying all the structures around it. What actually makes the diagnosis is that they are very, very hyperintense on T2 weighted images. Okay, the rest of the findings are not very specific. They are low signal on T1. They can have areas that they enhance with contrast. So typically, if you see it that is very, very hyperintense on the T2, you are going to make the diagnosis. In opposition, condorsarcomas, which are also from the skull base, they tend to be off the midline. The chordomas are at the midline, and they can occur from the clivus all the way down along the spinal cord. The condorsarcomas are off of the midline because they tend actually to be located at the petro-occipital fissure, so very lateral. They are also osteolytic lesions with solid component, highly with a high contrast enhancement, and with a very high aggressive imaging features. Then the other area that we should look about it's the cellar and superceller area, and there are many lesions that can appear, non-neoplastic and tumoral lesions. Here with A and P are the ones that are more common in adults and pediatric population. So I'm going to speak about the rectal cleft cyst, the adenomas, the metastasis, craniopharyngioma, the aneurysms, which are important, and arachnoid cyst we have already talked about, and you have microadenoma and also meningioma. So the first one is this one, which is a remnant of the cleft and is a benign cyst, and it can be located at the cellar region or at the subcellar cistern. And they typically have different types of signal intensities on MR, being the most commonly easiest to diagnose is when they have a high signal on T1. It's very typical if they have a high signal. They are very well demarcated, and they may have some contrast enhancement, rarely, but it's generally like a ring enhancement around the cyst. But these are benign lesions. The adenomas, they can be microadenomas, as you see here, small adenomas less than 10 millimeters, or macroadenomas, as you see here, larger than 10 millimeters. On CT, the microadenomas, you might not see them. If you give contrast, you may see that the adenoma area will enhance later than the normal pituitary gland. But you see this much better when you do MR. And the macroadenomas are typically shown as the snow men with this double circular appearance at the cellar and at the supercellar area. So looking through a microadenoma location, we need actually to do MR. And it's important to locate it because the surgery will be almost blinded. They will go to the part of the pituitary gland that they suspect to have the microadenoma. Here in a dynamic study, before contrast and after contrast in 2 times, you see that starting to enhance the normal pituitary gland, and the microadenoma is not enhancing, and in a later phase is still not enhancing. And it's this that actually helps you to make the differential diagnosis. You are not going to have that on macroadenomas, as you see here, the typical shape, so rounded and another round area. What is actually important to describe in the macroadenoma that makes the prognosis of the patient is the invasion of the cavernous sinus. Of course, you need to say that this macroadenoma is compressing the optic nerve and the chiasm, is displacing the vessels, and these vessels, it's important to see the anterior cerebral arteries that are there. It's also important to understand where is the normal pituitary gland and the pituitary stalk. Many times we cannot see that. But what is more important is try to define if there is a cavernous sinus invasion, because it's very difficult to take the macroadenoma on that location. And what are you going to look? You are going to look to the internal carotid arteries. If the internal carotid arteries is completely surrounded and with decreased diameter, for sure you have invasion. If it's completely involved by the tumor, so all around, it's invasion of the cavernous sinus. And if it's less than 180 degrees around it, probably it's not invaded, it's just displaced by the tumor. Another lesion that appears on this area, and it's when they have calcification, it's easier to make the diagnosis, are craniopharyngiomas. They have 2 peak incidents. They come on the pediatric population and later on adult population. And typically they can be cellar or supercellar, or cellar and supercellar. And what makes the diagnosis is the presence of calcification, the presence of different cysts with different signal intensities. And you see here an MR, so you see different cysts with different signal intensities, and you see the solid component that is actually enhancing with contrast. In this case, compressing the ventricles and causing an hydrocephalus. Looking at the paracellar, we are looking into the cavernous sinus. And what can we find in cavernous sinus? Of course, you can find inflammatory lesions that sometimes come from the orbit into the cavernous sinus. You may have vascular abnormalities of the arteries, like an aneurysm, or of the veins, dilated veins here associated with a fistula. And you may have tumors. Tumors of what? You can have tumors of the meninges, and you can have tumors of the cranial nerves that pass there. and these are the most common ones. Then, of course, lymphoma, as you know, can be anywhere in the brain. Meningioma can appear in the cavernous sinus, and metastasis also will be on the differential diagnosis of any extra-axial lesion. I want to show you this because CT is not enough to know what lesion is here. You cannot tell. You see that there is a lesion on the cavernous sinus, that there is some bone erosion there, as you see, but it's clear on the MR that you have a large aneurysm of the cavernous segment of the ICA. So MR is essential. Well, this is a lymphoma. The patient had a systemic lymphoma, but actually you could not tell what was the lesion that was here in the cavernous sinus inside compared to the normal place. And this could be anything. You need to actually work up the patient to know if there is some systemic disease. Could be a metastasis, could be, as in this case, a lymphoma on the intracranial manifestation of a systemic lymphoma. Another area of differential diagnosis that is important is the pineal gland area, or the posterior wall of the third ventricle area. And here you have non-neoplastic cysts from the pineal, or you can have arachnoid cysts, and you can have tumors, primary of the pineal, pineocytoma, with the intermediate differentiation, and pineoblastoma, typically from the pediatric population, and on adults, germ cell tumors like germinoma, and this was the case, and also meningioma on this area. Other lesions, what we have here the vein of Galen passing here in the internal cerebral veins. We may have vascular malformation on this area. Pineal cysts, we see this all the time, every day, so they are like demarcated cystic lesions. They can have CSF signal intensity or a little bit higher on the flare, meaning that they have some proteins inside. They generally are less than 1 centimeter. When they are more than 1 centimeter, we should follow them because it's impossible to make the differential diagnosis of a pineocytoma and a benign pineal cyst. It's the follow-up that will tell you. And generally they have no mass effect. They are incidental findings. You see, pineocytomas are more frequent in children, and you see the lesion here, very similar to the pineal cyst, but when you give enhancement, there is an heterogeneous enhancement of the lesion, and on the follow-up, this lesion will increase in size. Pineoblastoma is completely different. These are aggressive lesions with a very rapid growth and with that heterogeneous disposition with multiple scattered calcifications along the parenchyma of the tumor. Germinomas are probably more common to see, and they can be located at the pineal area or at the supercellar area, or both. They are also aggressive lesions. They may have hemorrhagic components, and this helps you to make the diagnosis. And they are heterogeneous, and it's the location and then the laboratory evaluation that is going to make the diagnosis of this disease, because beside the topography, the imaging findings are quite unspecific. And you see here, on this case, you have restricted diffusion of the solid component, you have multiple macro and micro cysts, and you have seen that the solid component with the restricting diffusion has a high cellular component was the one that was enhancing. Cerebellopontine area will be an area that you may have an aneurysm or a malformation, an epidermoid cyst or arachnoid cyst. You have seen that on CT they are equal. MR makes the differential diagnosis. Cholesterol granuloma of the petrous bone that actually expands into the cistern. Meningitis, generally pachymeningitis associated with sarcoid or other inflammatory lesions. Regarding tumors, the most common ones are schwannoma, as you see here. We have seen this picture before, and meningiomas. They will have an implementation at the dura, at the petrous bone, and also metastasis. And in very rare cases, you may have an endolymphatic sac tumor. What about intraventricular areas? Well, we may have also cysts, epidermoid cyst, arachnoid cyst, choroid plexus cyst. We may have tumors, and typically the tumors that are going to involve the intraventricular components are the ependymoma and subependymoma. Ependymoma more frequent in the pediatric, subependymoma in the adult population. Central neurocytoma is also more common in pediatrics. So whenever you see an intraventricular tumor, you have to think about this. The subependymal giant cell astrocytomas also may appear. They are associated with phacomatosis and neoplasms of the choroidal plexus, papilloma and carcinoma of the choroid plexus, typical also from pediatrics. Then you have many other tumors that can have an intraventricular location. Typical findings, because they are very common, is like this. You see this hyperdense lesion in the anterosuperior area of the third ventricle near the junction with the foramen, and this is a colloid cyst. On MR, they have different signal intensities, and regarding the signal intensities, they are more fluid or with more protein, and it's helpful to define if you can take it out, if it's needed, take it out surgically on an endoscopic approach. If it's more fluid, you can have better results than if it's not fluid. Then the other cysts that you may find, they may be at the choroidal plexus, as in this case, or they may be outside of the choroidal plexus. They have the same signal intensity as the CSF. We are going to call it ependymal cysts or choroidal cysts, depending on the location at the choroidal plexus or just in any other area of the ventricle associated with the ependyma. So the key point here is that actually they will follow the CSF signal intensity and density in all sequences. Well, papilloma and carcinoma of the choroidal plexus, these are tumors of the pediatric population. They are typically located at the choroidal plexus that you know, most commonly at the atrium, and the papilloma has a benign appearance. They are solid lesions, they grow, they have associated hydrocephalus, and it's controversial if they actually think so, that increase the CSF production. And when it's very heterogeneous inside the ventricle, even with multiple cysts and hemorrhagic components, it's going to be a carcinoma. And remember that also these lesions tend to disseminate through the CSF, so you need to do a neuroaxis study. So ependymomas, you find it also in the children, in the adult population. What is typical of ependymomas? The possibility to have calcifications, the possibility to have hemorrhagic components, cystic and solid components that the solid components can enhance. Another thing that is typical is that they go through the outlets of the ventricles, through the lateral foramen and through the central foramen. So Lusca and Magendie foramen, okay? And this is what is actually typical. One type of ependymoma, which is subependymoma, you see this more commonly in late adult age. They are inside the ventricles or lateral ventricles or fourth ventricle, and typically they will not enhance. And they will be there with now not associated with hydrocephalus because they are very slow growing lesions. So as a summary, so we have spoken about benign cysts that have a location, extra-axial location, arachnoid cyst, epidermoid, dermoid, and then those of the pituitary gland and pineal cyst. Some tumors, you need to think about meningioma, schwannoma, and metastases, and then tumors of each of the typical locations, pituitary gland, pineal gland, or interventricular. And then, obviously, on the topography, if there are vascular structures passing, you need to think about vascular problems, aneurysm malformation, or other types of ectasias. And in pituitary gland, you have other diseases that actually can increase the size of the pituitary gland, namely the hypophysitis and apoplexia. Okay, thank you very much for your attention.